Hello, everyone, and welcome to the sepsis lecture. Let's go ahead and get started. So first of all, the big question is, why do you care about sepsis? This should be a pretty obvious answer from all of these statistics, but it is the 10th leading cause of death in the US. Some are even arguing that it might even be higher. That's because of the COVID pandemic, of course. But all of this being said, because sepsis is such a leading cause of death in the United States, everyone is paying attention to sepsis. This includes even non-medical folks, like people who are in Congress who set the laws and rules for Medicaid and Medicare. This will become important later because a lot of legislation is passed about sepsis. We'll get into that next. The objectives for today are pretty simple. All I want you to know is what sepsis is, how to identify it, and learning something about how to treat it. Now, for those of you who have already been in the emergency department or maybe even have already been in the ICUs, again, this might be a little bit of a repeat because I know a lot of the nursing staff has to deal with sepsis on a daily. However, I want you to go through this lecture anyway and think about it from a provider's perspective. Think about what you would do in all of these cases. All right, I want to give you a quick little history lesson that I think is incredibly fascinating. And that is, we knew about sepsis from all the way back in the days of the gladiator. That's right. Hippocrates, which was the physician to the gladiator, happened to notice that some of the gladiators, they got stabbed or bit or cut in some way, and some of them would get better, but some of them would get infected. And some infections would be worse than others. And he called the worst infections something called septicemia, which he termed as blood poisoning. And this is the first listed identified cause of sepsis that we have all the way back in the days of the gladiator. Now, of course, back then, people who got sepsis almost always died because we didn't know the cause of it, and they were doing a bunch of strange practices. But since then, we've moved on to understand that sepsis is not just an infection. So just because you have a urinary tract infection does not mean you have sepsis, right? So you have to understand that sepsis goes beyond a typical normal functioning infection. There's some other component here to sepsis beyond just the infection. Now, we used to define sepsis as something called the SIRS criteria. And I put this here because some people are very outdated, including some tests, some preceptors, some even doctors are very much still using the SIRS criteria. So I want to explain it to you so you understand what people are talking about. Now, the SIRS criteria is listed for you here. You have to have more than 2 of those 4 listed. So you've got to either have a high fever, 38 or above, or a low body temperature, 36 or below. You also have to be tachycardic, but notice that they're using 90 here and not 100. Also, you have to be potentially breathing more than 20 times a minute, or you can have your white blood cells be either really high, above 12, or really low, below 4. And if you have more than 2 of those, that counts as having SIRS criteria. And we use this on and on for a very long time. But you didn't advance to sepsis until you had a presumed or confirmed infectious process. So you had to be SIRS positive, and then you also had to have an infectious process. From there, it moved on to something called severe sepsis, where you developed organ failure of some kind. Name any of the organs, right? And then from there, if you had some kind of hypotension, that's when you had septic shock. Now, look at that slide. You can see at the very, very bottom corner there, this slide is from 1992. So this stuff is really outdated, which is why we don't use SIRS criteria anymore. And to explain why, this is a set of vitals up here. You can see that somebody's blood pressure is doing fine, so it's not septic shock. And you can see that somebody is tachycardic. Notice that their oxygen sats are fine and the respiratory rate is over 26. Now, I listed for you here the SIRS criteria in the bottom white box so you could compare. If this person's white blood cell count is 14, they meet SIRS criteria. I think all of you can agree on that. However, what if I told you that this person wasn't even sick? What if I told you this person had just finished running a marathon? What about if they had just got the flu? What if it was just a car accident or a burn? These people qualify for SIRS, even though we know that there's not an infection and there's not sepsis. So that's been very, very frustrating for many, many years for a lot of providers. Now, what about this example? Notice that the person has a heart rate of 76, which is fine, and a respiratory rate of 18. And their white blood cells are 5, which is great. And they don't really have a fever, but they're pretty close. And what if I told you this was a cancer patient on beta blockers? They completely miss the oxygen sat of 84%. And maybe they have rails in their lungs. And maybe this person isn't tachycardic because they're on beta blockers. And they can't mount a white count because they just had chemotherapy. So this SIRS criteria completely missed this very sick patient who went to the ICU. So you can see here now that SIRS is too nonspecific. Somebody created this very helpful graphic for you to understand that trauma, burns, pancreatitis, many other diseases cause you to be SIRS positive. And you can see here that in the sepsis ball, there's tons of different kinds of infection that are missed by the SIRS criteria. So really it only encaptured about half to even a third of these sepsis patients. And so people realized that we needed a new definition and that SIRS was not perfect and it wasn't really helping people out. Plus, it was requiring a lot of patients, especially older patients who were SIRS positive all the time, to be admitted to the hospital constantly, even though there was no big problem. So a bunch of ICU doctors met in 2016 around the world, and they created something called the Surviving Sepsis Campaign. I'm sure many of you have heard about this. Now, one of the big things that they did is they decided to finally recognize in 2016 that they needed a new definition of sepsis, which was a positive in our opinion. So this is the new definition of sepsis. It's defined as its definition as organ dysfunction, and it's got to be life-threatening, and it's caused by a dysregulated host response to the infection. So we're saying that it's beyond an infection, so it's dysregulated, and it is a life-threatening organ dysfunction. So you have to have organ dysfunction to have sepsis. Now, the problem with a lot of these criteria and guidelines and that kind of stuff is that while this was a really good definition, a lot of the things that came out of this Surviving Sepsis campaign were not as helpful. And that is the QSOFA criteria, which is what is currently being used now. However, the QSOFA, the Q stands for quick, but the QSOFA criteria had 3 in particular: a hypotension, altered mental status, or tachypnea. Now notice that all of these are signs of big deal organ dysfunction. And you have to have more than 2 of them to have a poor outcome. Now, let me also go ahead and point out that probably without this QSOFA criteria, you probably knew that if somebody is hypotensive, they're altered, or they're breathing very fast, that this is probably not a patient that's doing well. So this didn't really add a whole lot to the medical community as a whole. So we use it as a mortality predictor, not really to diagnose sepsis, right? Because you could have sepsis for another reason and QSOFA wouldn't catch it at all. So they did come up with the SOFA criteria, and SOFA stands for Sepsis-Related Organ Failure Assessment. And it's listed down here. You can see that it's a decrease of the PaO2, it's a decrease of your Glasgow Coma Scale. But as you continue to get along in this SOFA score, deleting the quick part of it, you get into things like creatinine and oliguria. Now, the problem with all of this QSOFA, the not quick version of this, is that these were developed by a bunch of ICU doctors. There were no emergency medicine staff represented. And so we have to wait to admit somebody to the ICU until we can do a 24-hour urine and prove that there's oliguria, according to this protocol. There's other problems with this as well, especially because oftentimes we don't have a source of infection when we admit to patients to the ICU with sepsis. So a lot of people were really rubbed the wrong way by this particular Surviving Sepsis campaign. And you know how it always goes with people and their egos, right? So this criteria seems to meet a lot of things that the SIRS was not meeting. However, it is not a perfect guideline. And it's definitely something that everybody has decided needs to be rewritten because it's missing too many things, just like SIRS. And the next Surviving Sepsis campaign, we're hoping that the emergency medicine folks are going to be invited. So what we are doing is we're treating this kind of like a fashion update, right? So SIRS is out and Q-SOFA is in, but we're all expecting Q-SOFA to go out of style any minute now. As a matter of fact, even the most up-to-date emergency providers are not listing Q-SOFA on any of their chart documentation or when they talk to the ICU staff because everybody pretty much hates it. So that leaves us with, what do we do in the meantime for sepsis? So this is not, and I repeat, not any official definition, but this is my functional definition when I'm in the emergency department. So I'm looking for an abnormal body response to an infection that causes systemic inflammation and tissue damage leading to organ failure. So that means that the inflammatory process is going to be up somehow, some way, whether that be in coags, whether that be in white blood cell count, whether that be in D-dimer, whatever the process is, the inflammatory process is going to be elevated. And we're also going to have proof of organ failure. Now, I want to point out that I didn't use the word dysregulated here, although you could have. And the other place that we use the word dysregulated is usually when we talk about cancer cells, right? Cancer cells are dysregulated because it goes rapidly and it forms a tumor and it does a bunch of things it's not supposed to. And a lot of people have postulated that this incredible response, like out of the ordinary response to an infection, that is what sepsis is something to do with the same dysregulated process of cancer. Now, remember, that's just a fun idea. That's not proven. You can't take that to the bank with you, and you definitely may not be able to talk to all your preceptors about that. But the important part is that when sepsis is untreated, death results. So if you get better on your own at home, you probably didn't have sepsis. I'm also going to let you know that we still don't know, even today, why sepsis happens in some people and not with others. I also have to go ahead and make the picture even more confusing by saying that the lines between the COVID-19, especially the folks who are getting really, really, really sick, and sepsis are very blurry. We think that maybe the normal, quote unquote, the easy version of COVID-19, the people who don't require hospitalization, maybe those are the folks who are gotten the actual COVID infection, and the people who have been admitted are the people who COVID-19 is causing sepsis in. But sepsis looks a little different in COVID-19 than it does with everything else. This is still something that is currently actively being researched. And I'm really going to follow this very closely because I think there's a lot to be said about this. You guys are going to have a COVID lecture a little bit later, so I'm not going to go too deeply into this. The best way to talk about what sepsis is to show you. And so I want to start off with one of, I think, 4 cases to kind of explain what sepsis looks like. So because I'm not there with you, I am going to read the slide. I'm sorry. But we have this patient pictured here. You can see his vital signs and his temperature as well. And he's a 73-year-old male who came in from a nursing home. He's coming in by EMS and he's just not acting himself. And this patient was a real patient I had. So, you know, that we didn't get a whole lot of extra information from the paramedics or from the nursing home. The head nurse told the paramedic that he refuses to speak and wouldn't eat. But he normally has mild dementia and he's very pleasant and he speaks, but he's not speaking today. So family's not there and not in town, won't answer their phone. So that's helpful. And his chart information that came with him only lists the past medical history listed there. So basically, I don't know a whole lot about him, which means that we're going to have to spend a little bit extra time on his physical exam. So this is his physical exam for me that I copied and pasted from my chart. Now you can see that he is resisting exam on HENT. He won't open his eyes. He won't stick out his tongue. He won't let me look in his ears, that kind of stuff. He won't follow commands and he won't answer any questions, but he moves all four extremities spontaneously. So he probably didn't have some kind of stroke. Notice that he's got tachycardia and it's irregular. Remember, though, that he has a past medical history of AFib, so that could be normal for him. We're not really sure. His respiratory breathing is shallow and he has coarse breath sounds, but remember, he also has COPD listed on his past medical history, so that also could be normal. Not sure. His abdomen, he has a scar over the liver, but everything looks soft and he has normal bowel sounds, and I'm not sure if that's important or not. And you can see on his skin here, especially as pictured, that he's covered with lots of scabs and bruising. Any idea why that might be? Of course, I can't hear you, but the answer for me was, well, he's AFib, so he's probably on anticoagulation. So he's probably taking some sort of anticoagulants. That is also something that's really helpful to notice about the nursing home patients who can't talk to you. So, I can't get a whole lot more out of him. He doesn't seem to be in any distress at this time, which is all good. So we got to kind of figure out what we're going to do now. So we got to come up with our differential. And, you always got to think about stroke or sepsis or infection. We want to think about the big stuff, right? Because we're in the ER. So we're thinking MI, maybe this is just worsening dementia. Maybe he's just hypoglycemic and he needs to eat. Maybe somebody snuck him some alcohol. You never know what happens in those nursing homes, right? So in order to come up with our differential, there is a really handy mnemonic called AEIOU tips that covers all of the reasons for altered mental status. And I like this particular one because I print it out and put it on the back of my badge sometimes. And I take a look at it whenever I need to make sure that I have covered all of my differentials for altered mental status. So again, we've covered alcohol. We didn't really cover a seizure. So maybe he's postictal. Insulin, we can probably check his sugar. Overdose, we can definitely check his urine, although, his vital signs don't seem to indicate that this is an overdose. Uremia, we can think about checking his arms and seeing if he's a dialysis patient. Trauma, of course, we can scan his head and make sure he's not had some slow bleed that's now causing a subdural. Or infection, and of course, we're going to look for that. Psychiatric or poisons, so that's going to be our dementia or maybe our alcohol. And then stroke, we've already got covered, and we're not seeing any focal neurological signs. But again, we're going to be already doing a CT scan of his head. So once we have our differential in place, next step we can do is go ahead and go about ordering labs. Now remember, not all patients need labs, but this patient probably does because he can't really talk to us. So let's start with some of the basics. And to go through these step by step, I'm only going to order a couple of things at a time and then talk about them. So the big thing that sticks out to me here first is probably the white count, right? The white count of 25 is probably pretty high. Now, if you haven't already listened to my Anatomy of a CBC podcast, I highly recommend you do that, especially because you need to understand that white cells being high aren't always an infection. Remember that there are lots of other causes of white cells being high. These are just a few. And to learn more about that, I'm going to leave that to the podcast. But you can see that not all of those are even infectious. However, in this patient, we're suspecting infection number 1 because while this could have been a seizure, and that's why his white count is high, we're going to continue our investigation. So the white count being high is pretty nonspecific. Notice that there's also another lab that I've added in here at the bottom and I've highlighted in white. That's the lactate, right? It's 3.2, which is actually pretty high, even though it doesn't have a little exclamation point right next to it. And that's because that's how EPIC works. So just to clarify, lactic acid and lactate are essentially the same. The difference is that hydrogen molecule on the end there. So for our intents and purposes, lactic acid and lactate are essentially the same. Okay. That being said, lactate and sepsis go hand in hand. And that's really because the discovery and the development and the research of sepsis has also gone hand in hand with realizing and discovering that lactate is also high when sepsis is present. Now, for a long time, we thought that had to do with tissue perfusion. And while there is some degree of that, we've actually found that it's not as much to do with tissue perfusion as we thought. It is true that it's produced by anaerobic metabolism, and it's used by the brain and heart as fuel during times of stress. So remember that a high lactic level does not mean that the body is excessively sick, okay? It is the best prognostic indicator, though, that your body is under a stress response. So we still use lactic and in sepsis hand in hand, and it is considered a hospital metric. If you guys haven't heard of MIPS, then you should be aware of it now. MIPS is how the big government and hospital accreditation systems determine whether your patients are getting good quality care or not. And now that you're being a provider, MIPS is something that you need to be aware of. MIPS are rules that the government comes out every year, and they change every single year, and they're determining how your ER, ICU, and floor level patients are being taken care of. And if they're not done within a certain time period, then that is not considered to be a good quality or high quality patient care interaction. So a lot of hospitals get paid based off of whether they meet the MIPS criteria or not. And so that's going to come down to whether you're going to get paid, right? So we all have to pay more attention to MIPS than we want to. So the MIPS criteria for lactic is that you have to have a second lactic after the fluid bolus, and it has to be done in the emergency department. So that's something that you got to be aware of. Sadly, the fact that sepsis is the 10th leading cause. Remember how I told you that we were going to talk about that later? Yeah, we're talking about it now. So non-medical people have determined that this is the way that they can judge our skill level. Yeah. But lactic isn't just elevated in sepsis. It's also elevated in, look at that, liver damage, heart failure, anything where you have some catecholamines, like let's say right after a code, after you've been pushing a whole bunch of epi, okay? Even if the patient has come back and you've gotten the rhythm, they're still gonna have a really high lactic level. Or if you decided that you hated this lecture, you went out and drank a whole bunch of alcohol to try to forget it, that would also elevate your lactic level. So acute alcohol intoxication can also elevate your lactic. So you understand that it's not exactly perfusion, not the way that we understood it before. Okay, so now we understand that the lactic level is high and that the white blood cell count is high. And while together, that's still possibly pointing towards our sepsis. We're not 100% sure until we see that this patient has a fever, he's tachycardic, he's confused, and none of the other processes end up equaling anything else. So his head CT, for example, would be negative, and we wouldn't be able to find any kind of head bleed or stroke or any other sources. So at least right now, we're going to function off of this diagnosis for sepsis. However, we're not done with just the diagnosis, right? We still have one more step, especially in the emergency department. It's considered poor form if we don't at least do a little bit of investigation into finding the source of the infection. So this chart is what I'm going to call cheater medicine. And it's cheating because what you're doing is you're using statistics for easy decision making, I would say. So the most common sources of infection are always going to be lung and urine. So it's really poor form in the emergency department if you're going to admit a patient for a presumed infection and you don't have a chest x-ray and a urine. especially on this patient who could have signs of both. So that means that, yes, you have to make your nurse hate you and you have to get that cast urine specimen, even though he's fighting, because you have to try your best to find the source of infection. This is also included in pediatric medicine as well, unless you're going to send the patient home, which you would be more inclined to do in pediatric medicine than maybe adult medicine. Now, if those two sources are wrong, you also got to think about gut infections, intestine, diarrhea, that kind of stuff. And then you also need to think about skin infections. Now, notice that skin infections is one big deal that you can't order a test or a picture or a radiologic study for. You have to go into the room, strip the patient naked, roll them on their back, make sure they don't have a big old bed sore or they have a diabetic foot toe that's coming off or something like that. So you need to take an actual exam of your patient. You need to take off their shoes. You need to roll them. You need to help the nurses maybe get the urine cath, all that kind of stuff. You guys who are nurses know this a lot better than other providers. The value of the physical exam is really high in this particular process. Okay, so I'm not going to talk about this slide anymore, but I do want you to notice that there's a star on it. Moving on. Let's talk about this patient's labs. So we went in and we got the cath urine. The cath urine doesn't seem to show any infection. It looks like a pretty normal urine. We got that CT head that was pretty normal. And this is the chest x-ray. So I think you guys know that air is black and black air should be in the lungs. So if the lungs are white, that is not right. So this guy has a really beautiful right-sided pneumonia. This was his actual chest x-ray. So this guy has pneumosepsis. You gotta love the creation of terms here because we just smash pneumonia and sepsis together and call it pneumosepsis. So this patient probably needs to be admitted for pneumosepsis. Now, because he doesn't have any septic shock, because he seems to be doing well other than some slight agitation and possible sundowning, this patient is probably safe for the floor. So we need to go ahead and talk about how we're treating sepsis before we send him up to the floor. So the number one treatment for sepsis is IV fluids. This comes from the thought that maybe they're not perfusing their blood and organs and tissues as well as they should be. Some of this has fallen out of favor. However, the metrics or MIPS have not caught up with the current thinking. So that means that you're required to give a 30 ml per kg bolus within 3 hours of the patient's arrival per hospital MIPS policies. And if they're a child, you're required to give 20 ml per kg bolus. Now, this is not true and not held to the same standards in COVID patients, especially those that are really, really sick. We found that giving them extra fluids definitely decreases their morbidity and mortality in the sense that it makes them die faster, right? And we don't want to overload them. So definitely don't do this in the terms of COVID patients, but know that this is allegedly a requirement for septic patients in the hospitals right now. I really hope that this changes. I would also say that even if they're a congestive heart failure patient, you still probably need to give 1 liter of fluid to see if this improves their clinical status. So everybody always asks, how much fluids do we give if we don't give the 30 bolus that we're required to give? And some really smart people came up with these 4 goals of resuscitation. You either want to clear the lactate by 10% or normalize it. You want to keep the MAP above 65. You want to keep your cap refill more than 4 seconds in case it was lower. Or you want to make sure that your urine output is 0.5 ml per kg per hour. So if any of those are achieved, you can document that the goals of resuscitation and list what it is have been achieved and that you do not believe that more fluids need to be added. Okay. You can also do something called the passive leg raise test. You can see that what they're doing here is they're lifting the patient's legs. That's causing that all the venous fluid to pool in the trunk of the person, and it's about 300 mLs. So if all of that fluid rushes to the heart, returns right back to the heart, then and their heart rate slowly improves or their blood pressure improves minutely, then that means that they're fluid responsive and they probably are fluid down. They need some fluid. However, if raising these legs doesn't change the heart rate or doesn't change the blood pressure in any way, probably giving them more fluids isn't going to be fixing your problem. The next way that we treat sepsis is by doing cultures and antibiotics. So I've shown here the 3 things that you can culture. I'm sure that you guys are very intimately familiar with urine, blood, and sputum. I also want to make sure that everybody is very familiar with the fact that we don't need to order cultures on every single patient, right? These are for the sickest of the sick. These are for the patients that we're trying to know immediately are going to go to the ICU. We're not exactly sure where their infection is, or perhaps they're immunocompromised in some way. That's a diabetic or a cancer patient, or maybe even a child where we can't find a source of infection. Cultures do not need to be ordered for every patient. That's my personal soapbox. However, I will also tell you that cultures are on MIPS protocol. Yay! Cultures obviously need to be ordered before antibiotics are given. However, sometimes it can't always happen. In sepsis, blood cultures are negative over 70% of the time. And a lot of times, at least 20% of that, they're positive in one bottle and it's gram-positive. And that usually means that it's a contaminated bottle done because it's really hard to get really good blood cultures. So if a lot of this is contamination and it's only really 10% of blood cultures that are actually useful and positive, I don't know why we're getting them all the time other than the MIPS protocol requires us to. So you can make your own decisions. If your job or livelihood are being threatened because you're not getting blood cultures, you may need to order them. But know that they're not the end all be all, and every patient does not need a blood culture. Okay, move on. All right. Let's go into our next patient case. So we have an 84-year-old lady who had a fall from standing. Her family said they heard her fall in the middle of the night, and she was walking to the bathroom when she felt dizzy and her legs just gave out. She didn't have any pain with this. She just fell. She was feeling a little bit under the weather lately, and she's had no pain, nausea, vomiting, diarrhea, or shortness of breath. She looks a little pale and she eats very little. She really only has a few past medical history. She takes something for diabetes, hypertension, and hyperlipidemia. Now, I know when you hear the story, you're like, wait a minute, this doesn't sound that sepsis-y to me. But remember that weakness, dizziness can be very vague symptoms, and you have to include a broad differential for these. Notice also that one of your biggest clues here is your vital signs. Check those out. Her SATs are low. She's breathing rapidly. Her heart rate's high. She has a fever, and her blood pressure isn't the best. I don't think I can give you any greater hints. So sometimes it's not always in the history, right? The fact that she's a fever just cements it for me. But the fact that she has tachycardia, low blood pressure, and her SATs are low tell me that something's not right. Maybe this lady has anemia, right? Maybe she's bleeding from somewhere. Maybe she's a GI bleed. But then the fever is the kicker. So when I do her physical exam, she's got dry mucous membranes. She even has like that crusty layer of skin over her teeth because that's how dry she is. Very gross. Her pharynx is not red or swollen. She has no tonsillar exudate. She's not oriented to the ear, but she's following commands and she's very pleasant. She's tachycardic and tachypnic, but we're not hearing any crappy lung sounds, so that's not very helpful. And her belly doesn't seem to be causing her any problems. She does have a prolonged cap refill, probably because her blood pressure sucks, and she's clammy, pale, and very fragile looking. This lady is immediately going to go into the ICU. I think we can all agree. But we need to do a workup in the emergency department to try to figure out what's going on. And we can't just do a workup. We're going to be doing workup and treatment at the same time. So I'm going to be ordering a CBC, a CMP, a urine and a chest x-ray at the same time that I'm ordering fluid, right? So we're going to go ahead and get some of her labs back. But remember that we've already ordered her a fluid bolus because I'm pretty concerned, giving her dry mucous membranes, that she's fluid down. I'm also telling the nurse at the bedside, hey, I'm sorry, but we're definitely going to need a cast urine specimen for this patient. So if you want me to help, I'm happy to do so, but we got to get that done. All right. Now notice that this patient has a white blood cell count that's just undeniably high. We also want to notice that her hemoglobin and her platelet count are really high. Now this all together, the fact that all three of those are really high could mean that she is hemoconcentrated. Hemoconcentration means that there's not enough water in the blood, and so all the cells are going to seem really high. As a matter of fact, I wouldn't be surprised if the nurse came to tell me that they couldn't get any urine and that when they drew some blood, it was really hard and really thick because this patient doesn't have enough fluid in the serum to sort of like dilute out some of these cells. So if that doesn't make sense to you, please go ahead and give me a call or shoot me an email. But the platelet count being that high, hemoglobin being high, and white blood cell being high, that is hemoconcentration. So this lady, I would go ahead and give her the 30 ml per kg bolus for sepsis. I'm also going to be looking and noticing that her CMP labs, her liver labs, all of those look okay to me, other than that lactate. Notice that lactate is 4. Also notice that her urine is positive for nitrates. Now that probably indicates that she has a urinary tract infection. That could be why she got so dizzy and her legs gave out when she was walking. Now, just a brief understanding of urine, and I know you've probably already had some lectures on this, but I'm giving you some examples here of 3 urines that I've had, and I want to go through them left to right. So let's start with that first one. So we have an amber color, but we don't really care about that. So the very first thing that I always look at is nitrites. Like this patient, the only way that a nitrite gets into a urine is because a gram-negative bacteria has made a nitrite off product. Our body doesn't have nitrites in our urine at all for any reason unless a gram-negative bacteria is sitting inside the urine, either in the kidney or in the bladder, and is producing nitrites. That's the only way. So nitrates always mean gram-negative bacteria, and gram-negative bacteria mean that we can start antibiotics. Okay, so notice that none of these are going to be that easy. Now, the next thing that I look at first is going to be our leukocyte esterase. Now, leukocyte esterase is a byproduct of a gram-positive bacteria. Now, the problem with leukoesterase is that that's not always the go-to. You can't always hang your hat on this like you can with the nitrite. And the reason why is shown in this very first urine. So you can see that the squamous epithelium are 33 and that the bacteria are many. So we have normal skin flora and fauna that are gram-positive, like strep and staph, that live on our skin. So especially in females, when this patient probably peed in a cup, the urine actually has to flow over some of the skin to get out into the cup or the toilet. So this particular first urine is contaminated. We see that there are 33 skin cells in this urine. And what came with the skin cells? Probably the flora that live on our skin, the gram-positive bacteria. So there's no saying that this leukoesterase is from inside the bladder. Most likely it's from what bacteria are living on the skin. This is why if you've ever had any encounters with urology, they always ask for a straight stick or straight cath for urine because they want to know what's actually in the bladder. They don't want it to be contaminated. So that first urine is contaminated. Now, the second one has both leukoesterase and large blood, and you can see 39 red blood cells in there and only 10 white blood cells. Now, luckily, the squamous epithelium are only 9, so that's not really that contaminated. And there are many bacteria. Now, even though there are many bacteria, I never hang my hat on that because it's not very sensitive. So what I'm going to look at is the fact that we have leukoesterase positive, but we have more red cells than we do white cells. So this ratio is really important. If we have more white cells than red cells, that's a bigger deal because the white cells are bigger. You can see the picture of the neutrophil right next to the red blood cell. So we're always going to have more red cells than we are going to have white cells because they get through the kidney membrane easier, unless you have an infection. So this said, this middle urine here, this middle urine is probably a female on her period because she has more than a 2-to-1 ratio of this red blood cell to white blood cell. Maybe this person also has a kidney stone. Okay, there's a lot of reasons why there's more blood in this than there is white blood cell. So based off of that alone, I would not treat this person for a urinary tract infection. And then the last urine over there shows negative leukoesterase, negative nitrites, but you can see that there are 93 white blood cells. That's so many. And it's not chock full of squamous epithelium. There's only 12, and there's not that many bacteria, but they have so many white cells that this person almost has pyuria. It's probably got pus in it visually. That said, this person is definitely got an infection. So to summarize all of this urinary evaluation, you want to look for nitrite and you want to look at leukoesterase. If leukoesterase is positive, you next want to go and look at your squamous epithelium and make sure it's not contaminated. And then you also want to look at the red blood cell and white blood cell ratio and see how high those are. All right, let's move on. Let's go back to our patient. Notice that your nurse has come to get you because the blood pressure has really gone into the tank. So now this patient qualifies for septic shock. Okay. And I know this isn't the shock lecture. You're going to have a shock lecture here shortly, assigned to you and given to you by Brad. But you should understand that a blood pressure being low and a heart rate being high, especially with the lactate also high, always means shock. And you may also notice that these patients very rarely have a very good urine output. So these in combination should always tell you shock. So we treat those. I guess I should bring up this question first. The most common type of shock is going to be A, hypovolemic. Now, while it might be tempting to think that this patient has hypovolemic shock, this is actually not true. This person has distributive shock, which is actually septic shock. So septic shock fits under distributive. Hypovolemic just means that they got dehydrated and they weren't drinking very much. So an infection can be distributive. Again, I'm not going to go into this because you guys are going to have a whole lecture on it. So what we're going to have to do now is we're going to have to treat this, right? So she didn't respond to the fluids. Her blood pressure is getting worse. That means that since her MAP is not above 65, that we need to go ahead and start some pressors. Now, we care so much about your MAP because if your MAP is 60 or less, something is not getting perfused. Usually it involves an organ because your body is going to want to perfuse your heart and your brain the most. But your kidneys, your intestine, your spleen, all of those other organs, and your extremities, like your fingers and toes, are going to be really cold and not getting a whole lot of blood because there's just simply not enough pressure to get there. So anything under a MAP of 60 means that we need to start pressors, or we need to really closely watch and try some fluids to see if that fixes this. So you guys are going to be assigned a whole bunch of information on pressors. And I am not going to go really deeply into that other than to show you my cheater medicine protocol here. And that is your vasopressor of choice in most things should be Levophed now. Norepinephrine has been shown to be the best pressor to start with, and it's the go-to one for sepsis specifically. Next, you can add vasopressin if you need to. I add vasopressin only when the patient is very acidotic. And that could be in the middle of a code, and that could be during sepsis or any other cause of shock. So if for some reason this person is very acidotic and their lactic is going higher and higher and higher and higher, norepinephrine or epinephrine for that matter might not work because acidosis causes denaturing of proteins. So you can add vasopressin, which works really well in an acidotic environment because it's not a protein. I also want to make sure to bring your attention to dopamine, which is the worst pressor of all time. Everybody has agreed that in COVID, in sepsis, and everywhere else, dopamine should not be used. Again, you're going to learn a whole lot more about this a little bit later, but the reason is that dopamine activates all the receptors. And so while that's great, because if you don't understand what's going on, you can just activate everything, it also has the most long-term side effects and consequences. And yeah, it may be really easy to give, and it's already pre-done in a lot of code carts. It's the final Hail Mary if you have nothing else, but it is definitely the worst pressor. And so if you could give anything else, I would give it. And if you cannot give dopamine, I would not give it. All right. This slide comes from a different lecture that hopefully I'll be giving later, but if you're giving pressors, you need to be placing a central line. You can give peripheral vasopressors for about an hour. Some people say 2 hours, but you need to be placing a central line in a slow and controlled manner if you started pressors. My secret is to always start the pressor first and then place the central line because you'll get a better chance of actually putting it into the vein than you would if you haven't given the pressor. Remember that low blood pressure is going to make it awful hard to put it into the vein. All right, let's do the second to last case here. This is a 3-month-old, and this picture I got off of Google. This wasn't the real patient. This is a Hispanic male who presents with his parents for a fever. And you can see the vital signs here. They're telling me that he's not interested in eating and he just won't stop crying for the last 24 hours. He was born a full-term baby. He had no problems and he's all up to date with his vaccines. He's also had decreased wet diapers, like noticeably he's only had one in the last 24 hours. And his father says that he probably got sick because he tried to feed him some Mexican food 2 days ago. That's right. They tried to feed their 3-month-old Mexican food. And they were thinking that maybe it was too spicy and that's why he was sick. Yes, this was a real patient. No, I did not make this up. So one of the things that's always really hard for me in pediatric cases is that I never know whether their vital signs are normal or not. So I have this little chart here, again, printed on the back of my, one of my badge. And I'm going to look here and see that a 3-month-old should have a heart rate between 110 to 160. So 171 is a little bit high. So this baby is tachycardic. And babies should really never have 97 or lower SAT. So we really care that this kid has a 95% SAT. So we're going to go ahead and do a pretty thorough exam. We're going to notice that he has dry mucous membranes and that his back of the throat and the ears, they don't show any kind of fever. And this most concerning part of this is he's going to kind of cry with exam, but he doesn't have any tears and he doesn't really resist. It's kind of like this weak, pathetic cry, and he's just kind of really floppy. He's tachycardic and tachypnic, and his belly seems a little distended to me, but it's really hard to tell with kids. You know, they always have that little kid belly. What is kind of also concerning is that he's clammy and he's cool to the touch. And this kid scares me. You know, he's not really crying as much as I should. And I'm really scared for this kid. So I'm going to go ahead and have this heck of a long differential. I'm going to think sepsis is the top of my differential, and there's a bunch of causes that could cause it. Notice that there's tons of gut reasons why you could have sepsis in childhood. I'm also worried about things like meningitis, bacteremia, ear infections, even cancer for these kids. So I'm going to pull out the works. This is a kid that I would definitely order labs on. He's definitely getting fluids, and I'm probably going to go ahead and initiate antibiotics, even though I don't know what's wrong with him. So these are his labs. Hecka concerning. Notice that because his hemoglobin isn't that high, he's not that hemoconcentrated. So I am still going to give him fluids, especially because he hasn't made any urine output. But I'm also going to be really worried and pay lots of attention to the fact that maybe those platelets are reactive platelets and maybe he has a heck of an infection somewhere. So his lactate level is high, but I can't find any other causes. Chest x-ray looks okay. Urine, which was cathed, not infected. So I'm going to go ahead and order him some fluid bolus. We already talked about that, but we're going to get some cultures because I still haven't found a cause. We're going to start the antibiotics, and we got to find our source. So where else can we look? Well, maybe we could do a KUB or some kind of CT scan of his belly. We can make sure that we look in his diaper area for skin. We can make sure we look at his toes and fingers. We already did urine x-ray for pneumonia. We could do a lumbar puncture and tap him and see if he's got any meningitis, right? He doesn't have an ear infection, at least not when we did the exam. And cancer like leukemia, especially with the white count of 50, was definitely on my differential for this kid. So I'm going to keep looking and looking and looking. So I did another HENT exam and I did a flu swab. We did a lumbar puncture, which was negative. We did our KUB, which was normal. I even got a blood smear because I called and I was like, hey, I'm really worried about leukemia for this kid. It was negative. So finally, several days later, I got a call, 2 bottles of gram-positive cocci. This kid had bacteremia. But notice that I wouldn't know that until days and days later. And even though it's nice to know the answer, you have to get used to the fact that part of the answer for us, at least in the emergency department, is this kid is sick. He needs admitted to the ICU, period. If you don't have a pediatric ICU, it's time to transfer. And even though we don't always get the end of the story, you can follow up with it days later if you care, or if you don't, know that you already did everything you could. You couldn't find a source. You gave him antibiotics and fluids, and you moved on. All right, finally, our last case. So this lady, I will remember forever. I had her about a month out of residency, and she's this 28-year-old, very well-known drug user. She comes in all the time, and she was dropped off for vomiting, and she's vomiting all over the waiting room. And so finally she comes back. You see that you have a heart rate that's pretty high, and her blood pressure ain't great. She's definitely high, super high, but she's vomiting all over the place, and she's just sitting there like she don't care. She's flipping me off. She cursed my unborn children. She is very rude to staff. She says, yeah, she did some drugs, but she won't tell us where and or what and or when. And she just is like the most unhelpful person. So we get a bunch of blood work, and I also give her some Zofran and Phenergan to make her stop vomiting all over everywhere. I'm also trying to give her some fluids because her blood pressure is not the best. Now, when we order labs on this lady, we're expecting them to be pretty terrible because drugs do terrible stuff to you. So I'm not really sure what I'm looking for with the labs. I'm thinking maybe this lady just forgot to eat or something. So on exam, which I have to fight for, by the way, she's really dry mucous membranes. She only answers 3 of the orientation questions and just refuses to answer anymore. She's very agitated. She's tachycardic and tachypnic. I don't find anything special about her belly when I'm pushing on it, but she's covered in mud. She has prolonged cap refill, and I'm not sure if that's because she's homeless or if that, and it's cold outside, or, you know, it's because of the mud, or if she's actually septic. I'm not really sure. So I'm thinking this lady could have some sort of endocarditis or meningitis, or maybe she sold her body for drugs and she has PID. I'm not really sure. But you guys have the advantage of knowing that this is the sepsis lecture. So of course she has sepsis, right? But we're going to go ahead and do the labs. Notice that her urine is not that infected. Her chest x-ray is unremarkable, shockingly. She does have a white count, but I'm not sure if that's because of the drugs or what. I mean, if anything's going to make your white count high, doing IV drugs is probably going to be one of them. So I don't know what to make of this. I can see that she's pretty acidotic, but I didn't get an alcohol level on her. Still kicking myself for that. And I also noticed that her sodium is down. So I'm giving her a bunch of fluids and I'm thinking, I don't know, maybe she could be septic. Her vital signs are not really improving with the fluids, although she did finally make urine for us, as you could see by the UA. These are some examples of some findings on patients with IV drug use. So you can see on the top picture all the scabs where they've consistently injected themselves. You can see all of these scabs, and some of them are caused by injecting, but some of them are caused because when you get really high on meth specifically, you start picking at your skin. And I'm not really sure why. A lot of people talk about coke bugs or meth bugs, but you just start picking at yourself and you'll have scabs all over your whole body. You can also see this tongue finding where they call it, where you have white spots and dark spots. Nobody really knows why that is, but we do know that it's related somehow to meth that might be injected with Drano. Again, not really sure why. It's just something that you see a lot. In that bottom picture, there is a leg, and you can see all of the scabs and scars there. That's from skin popping. That means that they can no longer find a vein, so they start just randomly injecting into the skin. Sometimes they get too deep into the muscle, and they can cause themselves some abscesses. And since this girl looks like this, I'm going to strip her naked. Even though she gets angry at me and everything, I'm going to look over her entire body. I cut off all of her clothes, even though she was angry at me, trying to see if I could find an abscess or a skin cause of her infection. By now, she has mounted a fever, which could be the drugs, but I'm convinced she has sepsis. And I can't find a source because her entire body is covered in scabs, and some of it's red and some of it's not. And there's this one spot on her leg that looks a little more red than the others, but I don't know. So at the end of the day, I tell the ICU, hey man, I've looked everywhere. I don't know what's up. This could be a skin infection. I can't find anything except this one area on her leg, but she looks awful to me. She needs somebody to look at her. I can't find it. I need somebody smarter. I'm calling for an adult. That's what I did. And I admitted her to the ICU, and I got a phone call about 7 hours later telling me that she was dead. And the autopsy report showed me that she had necrotizing fasciitis in that area of her leg that I had been concerned about. I hadn't gotten an x-ray because I would have had to talk myself into getting an x-ray on her entire body because it was so difficult to find the cause. But as it turns out, low sodium and that lack of caring is also a symptom of necrotizing fasciitis. And I will remember this lady in this case forever because it was so difficult to find. And I had all of the clues in front of me and I didn't find it. The surgeon still tells me I should have called him, but I think if I had called him and been like, I'm not so sure without any definitive proof, I think he would have laughed at me and not come down to see the patient. But she did not have pain at a proportion to exam. She was immunocompromised because of IV drug use. It was allegedly rapidly progressive because I guess it went all the way up underneath her skin, up into her heart. And I did start antibiotics on her, but I didn't know what else to do. So anyway, this is one of those cases where you learn from my mistakes. So in summary, sepsis is an abnormal response to an infection, not just any infection. And there has to be organ damage present. And you have to die from this if we don't treat it. Okay. We still don't know why some infections are causing sepsis and some are not. but our treating sepsis and our MIPS criteria are all listed there for you. Notice that we have to give IV fluids, we have to give antibiotics. Notice that we don't always want to give broad spectrum antibiotics if possible. We want to treat the narrowest, most common cause first, if we can. Then we also have vasopressors. Notice that we want to start with norepi or Levophed always first. We want to find the source of the infection, and sepsis always requires admission because they'll die without it, right? So here are some red flags, and you have to have these red flags with an infection to be qualified for sepsis. And finally, here are some references. If you guys are interested in checking out the Surviving Sepsis campaign related to COVID, I listed the really good reference, very easy to read, down there in white, the first 10 in EM. That's a great place to go. Here are a couple of recommendations for sources and resources that I personally recommend, especially this EMERA antibiotic guide. It's worth every single penny. There's actually a 19th edition out right now. Highly recommend if you don't have. I also really like downloading Medscape, especially for on your rotations. There's a lot of information there about surgeries or treatments. I really like the Rebel EM website, especially because it has lots of good discussion on up-to-date COVID information. And then the last is this resuscitation app. It's a really good app where you can practice taking care of patients and doing orders and having differentials. And it's free to try, but it's $5 per package. So you can check it out, see if you like it with the first 3 or 4 cases, and move on. Finally, we are at an end. Thank you guys so much for listening. Please feel free to get a hold of me if you need to.